Everyone. The patient we'll be talking about today is called Sally. She's a 28-year-old female who has been brought into ED today by ambulance after collapsing at work. She is lethargic, mildly confused with increased urine output. Sally's work colleagues have told the paramedics they've worked together for 5 years. They've explained that over the last couple of days, she has not been eating very much at work and has been very tired, often arriving late. Today, upon arrival, Sally was having a conversation with a colleague and collapsed. She currently lives alone due to a recent relationship breakup and has taken the odd day off work. Her colleagues were not aware of any cultural preferences or beliefs, and Sally is currently unable to tell us due to her confusion. Since her relationship breakdown, Sally has been highly emotive and has often been upset at work, and her colleagues have said this is extremely out of character for her. Since being in A&E, Sally's had a set of initial observations, which you can see on the board, and has also had a full set of bloods and an ABG. I believe we passed around some ABGs. I don't know. Yeah. So we just very briefly just wanted you to look at the ABGs and just see if there's anything that stands out to you. If not, then that's fine. We'll move on. But if there is anything, give it a shout. Do they look normal? Yeah.
Is it the same as what's up there?
Yeah. So we're just because obviously.
Oh, sorry.
I didn't realise that.
Yeah, I just kept it for me. Sorry.
Is there anything that stands out for anyone?
Yeah.
So Sally has a past medical history of anxiety and depression. She's type 1 diabetic and she has anorexia nervosa. And according to her record, she has been admitted in the past with the same symptoms. After all her observations were completed, it was diagnosed that Sally was hypoglycemic, and based on her blood results, she was in diabetic ketoacidosis. The criteria for DKA is a blood glucose level above 11 millimoles, with ketonemia above 3 millimoles, and with a pH below 7.3 or a bicarbonate of below 15 millimoles. Diabetic ketoacidosis is an acute metabolic complication of diabetes, which is categorized by elevated blood glucose levels, elevated ketone levels, and metabolic acidosis. The elevated blood sugar levels cause a disruption to electrolytes and loss of fluid due to osmotic diuresis. DKA is caused by poor glucose utilization due to insulin deficiency, forcing the body to metabolize triglycerides and amino acids for energy. This is called ketogenesis, and the byproduct being that ketones are excreted into the bloodstream, which is called ketonemia. Sally is at high risk of DKA due to her type 1 diabetes, which is considered to be an autoimmune disease, meaning the beta cells within the pancreatic islets are destroyed by T lymphocytes, causing insulin deficiency and hyperglycemia. Type 1 diabetes is predominantly diagnosed in adolescence, but has a peak onset around puberty. This differs from type 2 diabetes, which can be a result of two main issues: limited and effective secretion of insulin from the pancreatic beta cells, as well as the cells in the muscle, liver, and fat being unable to use secreted insulin effectively. There is also current research taking place into type 3 diabetes, which is thought to be linked to poorly controlled blood sugars, increasing the risk of being diagnosed with Alzheimer's later in life due to the brain being unable to respond to insulin produced in the pancreatic beta cells.
Well done. So I'm going to be talking about the normal and abnormal physiology of a patient who does not have diabetes and one that does. So normally, in a normal patient, the liver is is the largest organ in the body and is responsible for many actions such as metabolism, immunity, digestion, detoxification, and vitamin storage. It's located in the right upper quadrant of the gastric region, so up here, and the liver has 4 lobes and is supplied with oxygenated blood by the hepatic artery and nutrient-rich blood from the portal vein from the capillaries of the digestive tract. Deoxygenated blood is then drained from the liver by 3 hepatic veins. Each lobe is made of tiny hepatic lobules, and these are the functional unit of the liver. These are hexagonal in shape and contain hepatic cells which absorb nutrients from the blood supplied from the small intestines and creates and secretes bile, which absorbs fat and carries waste that cannot be processed by the kidneys. Absorbed nutrients are then broken down into the liver into functional sources of energy, which can be used around the body. The pancreas, which is this section just here, has a similar role in the digestion process. It's situated in the abdomen and is surrounded by the stomach, small intestine, liver, spleen, and gallbladder. It's got two primary functions. The first is the secretion of enzymes in pancreatic juice, which connects to the common bile duct to help with the digestion of fats, carbohydrates, and proteins. And the second is for blood sugar regulation. Insulin and glucagon are the two main hormones that the pancreas secretes via the islet of Langerhans cells into the bloodstream to either raise or lower blood sugar levels. The pancreas works with the liver, where stored glycogen in the liver is converted into glucose by the secreted hormone glucagon from the pancreas. When glucose is secreted from the liver, insulin is also secreted from the pancreas and acts as a lock and key mechanism to allow the glucose to enter cells and to be broken down in cellular respiration for energy. Blood then moves through the kidneys, where insulin and glucose are filtrated. Glucose is normally freely filtrated in the glomerulus, and almost all of it is reabsorbed in the proximal convoluted tubule. However, in diabetes, circulating blood glucose exceeds the threshold for reabsorption in the tubules, which means that large levels of glucose are excreted in the urine. So diabetes can significantly impact these three main organs. Diabetes significantly increases patient risks of developing fatty liver disease. I'll pass these around. These are just some scans of both a normal liver, one with non-alcoholic fatty liver disease and one with non-alcoholic steatohepatitis. So consistently high blood glucose levels and insulin action, the glycogen synthesis pathway, so where the glycogen gets changed into glucose, can become saturated. This causes carbohydrates to be converted via the lipogenic pathway, resulting in the production of fatty acids within the liver cells and the development of non-alcoholic fatty liver disease. Paired with inflammation of the liver and damage to the liver cells, this can cause non-alcoholic steatohepatitis, leading to liver cirrhosis and liver cancer, as well as increasing the risk of cardiovascular disease and death. So as you can see, kind of compared to this on the screen, the non-alcoholic fatty liver disease significantly enlarges the liver within the body, and just causes a lot of deterioration. Type 1 diabetes can also cause atrophy of the pancreas. So I have another scan here. I've only got two, I'm afraid. But I have a little look at this one. There you go. So the pancreas. Can anybody tell me where the pancreas is on that? Do you think? Which thing?
What bit?
Yeah. So that's where the pancreas is. Type 1 diabetes can cause atrophy of the pancreas, resulting in reduced size and function. This is due to the lack of insulin, which is a potent growth factor and vital in the endocrine and exocrine relationship. Acute kidney injury is also a classic complication of DKA. AKI is characterized by a sudden deterioration of renal function, usually accompanied by a decrease in urine output. In patients with DKA, an AKI proceeds mainly from hypovolemia due to glucose-induced osmotic polyuria. When insulin is administered, blood glucose levels become more stable. Fluids are also given to help improve lost volume, which can then increase perfusion and reverses DKA and AKI. So I'm going to pass you to Mollie now.
I'm going to talk about the endocrine and exocrine and how it has an involvement in this. The pancreas is known as the mixed gland. This is because it has both endocrine and exocrine functions. The endocrine function secretes hormones directly into the bloodstream to target an organ. For example, blood sugar control is insulin. The pancreatic exocrine function is the secretion of enzymes through ducts into the duodenum and then into the gastrointestinal tract. For example, the Brenner's gland, which is in the duodenum, is mucus protecting the duodenal lining from stomach acid. In individuals with type 1 diabetes, the function of the pancreas fails, meaning the insulin secreting and endocrine function is inhibited. On a cellular level, insulin acts by directly binding to its receptors on the plasma membranes of the cells. These receptors are present on all cells. The insulin receptor is a glycoprotein consisting of two subunits, alpha and beta. Extracellular alpha subunits have insulin binding site. Beta subunits have tyrosine kinase activity, which acts as an on-off switch for many cellular functions. When insulin binds to the alpha units, it activates the tyrosine kinase activity in the beta subunit, and this causes translocation of glucose transporters from cytoplasm to cell surface. These glucose transporters then allow the influx of glucose from the blood into the cell, which reduce blood glucose levels.
So I'm just going to talk about the treatment of DKA. So I've got here, this is the, as I got that mark from that one, and this is the sort of pathway that we use at four hospitals to initially manage DKA. So primary treatment in DKA is to restore metabolic homeostasis, whilst also minimising any risk of complication, such as like making their sugars go the other way and causing them to become hypoglycemia. So immediate management really that needs to be carried out in the first hour is a restoration of circulatory volume. As we've sort of touched upon, patients with DKA are often profoundly volume depleted due to vomiting, or in Sally's case, because of reduced oral intake, and also increased urination because of the body trying to get rid of all the excess glucose. And on top of this, when someone's in a hypervolemic state, the body actually then it basically triggers a release of stress hormones, like counter-regulatory hormones like cortisol, which then causes further insulin resistance, and then that exacerbates DKA. So then there's no point in just straight away giving insulin, because it basically won't be accepted by the body. So the body needs to have the volume put back in first. So what we do is we give, so on the chart you'll see, depending on the patient's blood pressure, Sally's is over 90. So we would give an initial, we would give 1,000 mils of saline over an hour. And then depending on her sort of electrolyte levels, we would monitor from then on and put her on like a fluid replacement regime. Once the fluids are running, we then need to look at giving the insulin. So giving insulin essentially allows the pancreas to slow down the secretion of the hormone glucagon, and therefore it stops the conversion of the glycogen into glucose. So it stops it from carrying on to be built up in the blood. So therefore we need to give the insulin through IV to go into the bloodstream quickly to get it down quickly. So initially on the drug chart you'll see we give 50 units of Act Rapid, which is diluted into 50 mils of saline. And this will be infused at a rate of 0.1 mils per the patient's weight per hour. So I think we said 5.1 units per hour. Just some side effects with Act Rapid. Quite obviously it can cause hypoglycemia, but we would hope because we're monitoring the patient's glucose levels that this wouldn't happen. They can also be at risk of edema, low potassium, headaches, and lipodystrophy. So just a little bit about Act Rapid. So it's a human insulin, and it has a structure and a function that is similar to those of natural insulin. So the benefits, it can also be combined with the patient's intermediate or long-acting insulin as well. However, because Act Rapid is quite short-acting, the patient might need to have sort of several hours of this medication until they get down to the levels that they need to be on. Once we have got that sort of insulin infusion running, we then need to be mindful of the patient's potassium levels as well, because in DKA, there can be quite a total significant body deficit of electrolytes like potassium. So what happens is in DKA, potassium is actually forced into the extracellular space, and it's replaced by hydrogen ions, sort of as a compensatory measure to correct the acidosis. So initially, the patient's potassium levels actually go up, but because of the amount of volume that the body's getting rid of through urination, the potassium then goes down. So we have to really keep an eye on that. I haven't actually got what Sally's was. Have we got what Sally's was? No, for potassium. But if it was above 5, it's 4, okay. So she would actually be okay. Well, she would need to have, if her potassium was above 5.5 millimoles per litre, she wouldn't need to have any replacement, but we still need to regularly monitor it. If it's between 3.5 and 5.5, which hers is, we would give 40 millimoles per litre. And anything that was below 3.5 would need quite an urgent review and potential for ITU. Yeah. Do you know that? Yeah. Because obviously low/high potassium can obviously lead to cardiac problems, arrhythmias, even cardiac arrest. So really ongoing management is to just get clearance of the ketones out of blood, get the blood glucose values to fall within a decent range of between 8 and 12 millimoles, maintain the serum potassium, like I've said, in a normal range, and continue to hydrate the patient before and then considering to a subcutaneous insulin, which Claudia will now talk about.
Following from Abbie, I'm going to talk about the route. So how the insulin is given, why the insulin is given intravenous, subcut, and why is not given orally in DKA. So as we learned before, previously, intravenous insulin is initially administered to patients in diabetic ketoacidosis to treat dangerous high blood sugars levels and correct the acid, base, and electrolyte imbalances. The patient will also receive the regular long-acting basal insulin, which is injected under the skin into subcutaneous tissues. Subcutaneous administration is used to help and prevent the rebound of hypoglycemia when insulin is discontinued. Insulin is discontinued as the subcutaneous tissue has the minimal blood vessels, allowing the insulin to be absorbed into the body at a slower rate compared to the IV insulin. Now I'm going to talk about some factors that can affect the absorption of insulin given subcutaneously, and they are the depth of the injection and the technique. Injecting it into too deep into the muscle can lead to a faster absorption, which might not be aligned with what we intended in the timing of insulin action. The insulin type, different types of insulin have varied absorption rates. For example, rapid-acting insulin is absorbed more quickly than the regular insulin. The thickness of the tissue. Thicker tissue may slow down the absorption, and insulin concentration. The concentration of a strand of the insulin solution used can affect the absorption. So higher concentration may lead to a faster absorption. So now we're going to talk about the bioavailability. So administering insulin directly into the bloodstream by IV injection and by IV provides 100% of bioavailability. This means that the entire dose of insulin reaches the bloodstream and is available to act on blood sugars immediately. The second point is that insulin, injecting insulin under the skin or subcutaneously is a common and effective route of administration, and it provides 90% of bioavailability, which is also quite high. However, it is not 100% effective as it might be metabolized or broken down or degraded during the transport process through the lymphatic system. Subcutaneous insulin has a reduced bioavailability, but it still offers a good and efficient treatment. And the reason why it's reduced, has reduced bioavailability is that due to a few factors like metabolism. Some insulin might be metabolized in the body's enzymes before it reaches the bloodstream. By degradation, during this journey through the lymphatic system, some insulin molecules may break down, reducing the amount of that ultimate enters to the bloodstream. So now we're going to talk about why insulin is never given orally in DKA. And this is for several reasons. Number one, high molecular weight. Insulin has a large complex molecular structure, which makes it difficult for it to be absorbed through the digestive system. The second one is a strong hydrophility. Insulin is highly water-soluble hydrophilic, means that has a strong tendency to dissolve in water. This properly further hinders its absorption in the digestive tract. It has poor stability. Number three, insulin is sensitive to degradation in the acidic environment of the stomach and by digestive. Excuse me, I want to say that again. Insulin is sensitive to degradation in the acidic environment of the stomach and by the digestive system, making it ineffective when it's taken orally in such cases like Sally. And low bioavailability. When insulin is taken orally, less than 2% of the dose, 2% of the dose is actually absorbed into the bloodstream, resulting in a very poor effectiveness in the controlling of blood sugar levels. Now pass it on to Abbie.
So as you can see on the drug charts as well, so she's on the Lantus, she's on the actrapid, but she's also taking sertraline for her depression. Sertraline is a selective serotonin reuptake inhibitor, an SSRI, which increases serotonin levels in the brain. Serotonin is a neurotransmitter which carries chemical messages between synapses in the brain. Normally, it's then reabsorbed by the nerve cells once the message has been carried. However, sertraline blocks this reabsorption, allowing the serotonin to be carried further to nearby messages. There are some side effects from taking sertraline. These can include constipation, headaches, malaise, and weight changes. They're often used as a first-line pharmacotherapy for depression and numerous other psychiatric disorders due to their safety, efficacy, and tolerability. So the dosage is normally 50 milligrams per day, which is what Sally currently takes, with a maximum dosage of 200 milligrams per day. Its elimination half-life is 22 to 36 hours, so normally a once-a-day dose is therapeutically effective. As seen on the drug chart, Sally continues to take her dose as an inpatient, although there are some contraindications that would also need to be considered in administering sertraline. These can include cardiac diseases where sertraline can cause arrhythmias, as well as patients receiving ECT, which is electroconvulsive therapy. There's some research that kind of backs for and against it. So it can induce a seizure-like state paired with the ECT. However, ECT alone is quite a short-acting therapy. So patients can go into withdrawal if the sertraline is stopped. So yeah, she's continuing to take her sertraline as well.
For Sally, the combination of treatment and ongoing monitoring with 1 hourly VBG, so it showed a correction of her hypoglycemic state. And this is her most, where do you put it? This in the green is her most recent VBG, and then also her obs have been repeated. So as you can see, the pH has corrected itself. Base excess has thankfully come back to within normal ranges. Everything's come back within a normal range that we would expect with quick acting DKA treatment. And just talking about the underlying contributions of Sally's DKA. Obviously, Sally's been primarily treated for her DKA, but later on she was assessed by the MDT. And due to Sally's previous admission, she was already known to the mental health team and was quite forthcoming in disclosing that her difficulties with food and fluid intake and her insulin therapy. Her poor management in her insulin therapy caused her hypoglycemic state, which has resulted in her DKA. And it's documented that up to 30% of individuals with type 1 diabetes are more inclined to have a negative relationship with food and weight. And this is a recognised condition called diabulimia. This is the act of reducing or swapping insulin to reduce their weight or lose weight. And in relation to Sally, the stressor of her relationship breakdown has impacted her control over her eating disorder, which has caused a relapse in her diabulimia.
I was hoping you just carry on. I write red again, like yeah, so moving forward, the following options were offered to Sally. So a review by the dietitians to offer education and advice on managing her diet and diabetes along these will need to consider mental health aspect and how eating disorders is to be assessed, and Sally to be reported to avoid any further problems or deterioration. Review by the mental health team. Obviously, there's a community mental health team as well in most every area. So we've got one in the hospitals, and we've also got one in the community when she's discharged to carry on having that care and support. She can also access counselling and therapy services. And lastly, a review by the diabetes nurse is a crucial element to prevent future admission into the hospital it would be appropriate for the diabetes nurse to speak to Sally and offer structured patient education, behavioural intervention and support. For example, they can discuss with Sally the importance of continuing insulin, blood glucose and ketone monitoring, adjusting doses and the supplemental insulin and instances where healthcare providers should be contacted.